Dr. Hans. In 2000, I received my MD and started on a path of internal medicine and infectious diseases. In 2017, my son was diagnosed with SYNGAP1 syndrome, and I became a rare disease advocate. In 2021, I joined industry to work on rare diseases as much as possible. So today we're going to talk about ICD-10. And I would love to say that I enjoy talking about ICD-10, but it's painful. So let's go. On a happy note, I recently found out that I teach at Jefferson, a med student, a very busy medical student, received not just one, but two ICD-10 codes for her advocacy efforts for central centrifugal cicatricial alopecia, as well as frontal fibrosing alopecia. So major congratulations, because now those become granular, easier to measure diseases within the US healthcare ecosystem. They have their own codes. They'll go into databases, insurance databases, as specified diseases, patients, care, medications, all of it tied directly to those illnesses. So just fantastic. It's a challenge to get a code. The fact is that, I think it's reasonable as previously a doctor to say I took them for granted. You know, it was an index card in my pocket for ICD-9. And then when ICD-10 finally came out, essentially a whole sheet of paper front and back with 95% of the codes that I needed to do my work. And essentially you go around, whether it's in a clinic or a hospital, and consult on patients, leave a note behind, talk to the team, and then you'll write down your billing. And if it's a 99255 for a follow-up or a new patient, high complexity, you have to justify that with their illnesses. And if they've got HIV infection, 042, if they have a MRSA pneumonia, J15.212, now you're justifying the intensity of care that you've provided to them. And, the rare diseases have been the last ones to get into the ICD-10 system, so they don't reap the benefits that other diseases do. And those include really epidemiology of that disease, the study of its distribution, occurrence, then also the healthcare costs associated with the disease. So if you can imagine, these giant insurance databases have got a whole lot of codes within them for the patient encounters for the year 2024. And vendors can mine that data and say, here you go, here's all the codes related to MRSA pneumonias, J15.212. They're broken down by additional codes of 042. So you see how many HIV infected patients have MRSA pneumonias versus those with hepatitis C, this code, that code, etc. And it creates visibility, right? And data for an illness that can really translate into conclusions. And those conclusions can include healthcare resource utilization, or the burden on the US healthcare system from that disease. How much money goes towards its care, hospitalizations, medications, etc. And I'll give you an example here where this is a claims database studying spinal muscle atrophy and what's the impact of gene therapy, Zolgensma, on the utilization of healthcare resources. Does the disease, the benefit of the medication, the cost of the medication, does the equation work out for the use of that medication? And I would love to have this for SYNGAP, because then at least I could answer the question that has been posed on a couple of occasions is, how much does it cost, right? How can I turn the argument of this is how much it costs each year to care for these patients. If my medication improves their circumstances, improves their care, makes it less intense, and saves the American healthcare system money, how much can I charge for it? And unfortunately, that may be estimated and kept private within biopharma industry interested in SYNGAP, but it's not public. And it's not cheap to get, but can be very informative. When it comes to getting that ICD-10 code, you have to take a step back and make sure that you've got a position within the NIH GARD system, or the Genetic and Rare Disease Center, because this is where an established, agreed upon disease will get listed and acknowledged in a way. So, if there's one case report of an illness, people are like, it's just one, it should be repeated like science likes to see. There was an illness back in probably the 90s that was talked about, Morgellons, and the CDC had to conduct an investigation, and it never reached the evidence threshold to be considered a disease. So that's not going to be within a database. That's not going to get an ICD-10 code. But hopefully your disease of interest is already in GARD. If not, talk to them about it. Get it listed there, because that's really the first step. CMS, the Center for Medicare and Medicaid Services, and the CDC want to have congruence between what's in ICD-10 and what's in NIH GARD. So start there. And then when you're ready to tackle the ICD-10 code aspects, I would go ahead and use the Every Life Foundation roadmap for the ICD code system. I was really honored to be included here as a case example with SYNGAP. It took a while, and sort of at a first iteration, there was a plan up front and then a backup plan. The first plan was to try to code based on the gene. And if you can imagine, it would just be a code that said pathogenic SYNGAP variant. And that could be applied to other diseases as well. And the code would have a unique attribute related to the Human Genome Resource Committee label of the gene. So it started off with one plan to code by the gene, but unfortunately, the committee deferred on that one. I was also told the ICD-10 system was too brittle to handle coding by the gene. So we just submitted what they wanted, a code for SYNGAP1 syndrome, or SYNGAP-related intellectual disability at the time. And that's now been around for just over 2 years. So there's a pretty good amount of codes, patients, etc. within the databases to be mined and hopefully put to good use. The remainder of this roadmap really helps illustrate how to go about getting a code. From there, you can take a look at the Coordination and Maintenance Committee's website, and you'll see the materials that people have submitted in the past to get their codes, and you can just model yourself based on the successful applications that have been previously discussed. The meetings are twice a year. And I'm not going to go into huge detail because it's really, really well laid out nowadays. Now, I don't like to criticize without a solution being proposed at the same time. I mean, the fact is that I think it's lazy to just criticize and not offer, a solution. And in all honesty, I think, the ICD-10 system could be much more proactive in assigning codes to diseases, right? Here we are as citizens submitting to get codes when you could really just have a handful of docs, working remotely, using some sort of generative AI tool to fill in standardized questions on a rubric, essentially for a disease to get an ICD code. So if, you've got a disease without a code, imagine it was, frontal fibrosing alopecia before October 1st, and a doc would use ChatGPT and say, what's the epidemiology? What are the symptoms, etc. And you could fill in this basic information and say, okay, so this is going to go into the dermatology section associated maybe with scalp disorders, hair, etc. And it'll slot right in here. And these are the other diseases it's close to. Then at the end of the week, you present it to your boss. Here's where I'm proposing frontal fibrosing alopecia go into the ICD coding system. And you could really just chip away, right? The 4 docs could break it up into A through G, et cetera, and so on. In addition to the, citizen activists submitting for the disease of their interest. I want to believe it could just be easier, right? Here's a system I feel entitled to understand, but I don't. And it makes me frustrated. Especially when MDs, similar to myself, have taken a Hippocratic oath to help, and you hear about just disappointing experiences of the rare disease community. I sort of got my first exposure through the SAT-B2 committee or disease advocacy group, because they were being told it was too infrequent and it should be indexed. And indexing is just sort of putting it into a 959.9, and there's a dozen or 24 other codes there. So there's no granularity. You can't study the disease if it's in a bucket, if it's been lumped. And lumping and splitting is a phrase in the sort of disease taxonomy world. And if you're just lumping diseases together, they don't get the benefit. And it's not as if this is, resource intensive. It's just a matter of some taxonomists and some docs and some federal administrators aligning on where to put a disease in the code. Every American is touched by this. This is absolutely something that I would consider a public service. From birth to death, there's going to be an ICD code system applied for your interaction with the healthcare system. So the idea that a rare disease is not sufficiently common enough to merit a code is totally inappropriate to me. I think it's discriminatory. When we were awaiting our SYNGAP 1 code, the plan or the backup plan was to have a letter complaining that it was against the ADA. You can certainly go if they've, and I've said it for years, but people are very polite and want to be harmonious. But I think at some point you just gotta say, you know what? I've tried to be nice and I'm not getting anywhere. And this was recently discussed by Amber Freed of SLC 6A1 on an Effie Parks podcast. And she's absolutely right. You need to take the gloves off, but a letter writing complaint campaign I don't think it'll be effective. Maybe some folks have already filed complaints. Maybe it's class action. I don't know. But Bo Bigelow certainly knows how to frame the argument. I've also heard that doctors, pediatricians are in on some of these meetings and saying, well, we don't really want another code. We really won't probably use it. And again, as a doctor, I think that's deeply offensive. If I heard somebody say that in a meeting I was in, I would write them up for unprofessionalism and I would submit it to the Board of Registration at the state that they practice medicine. There's a bound duty to help patients, and ICD-10 codes help patients. So I hope you take no prisoners on this one. The fact is that ICD-10, they kicked the can down the road 3 years. We were told, get ready, we're switching from 9 to 10. We're putting it off for a year. We're putting it off for a year. I think it finally kicked in that third year. And that's because you have to bring everybody kicking and screaming into the next system. The payers are worried. The hospitals are worried. The healthcare systems, the docs, the practices. because either they're going to pay out money or they're not going to get reimbursed enough. That's what their nightmare is. So here's ICD-10, and it's also a bit of a lame duck, right? Because ICD-11 is on its way. It's already been rolled out by the WHO, but it's a whole different beast. I mean, we're going from algebra to calculus on this one. And hopefully there's some AI tool, that's going to just extract it from the notes and submit the billing on behalf of the doctor, because the docs, their heads are going to explode when they see it. I'll talk about ICD-11 in another podcast because I think it's critical to get in there now. It'll take a couple of years. And in the meantime, I hope you fight for your ICD-10 code because it will make a difference for you. All right? Great. No beeps or bleeps and nothing to be embarrassed by, hopefully. Thanks. Bye.